to have you all with us here on one of our semi-regular health breakfasts, depending on what else is happening on a Sunday morning. Next Sunday, for example, we're going to be doing an Israel seminar that you can join in. So we won't be doing a health breakfast. I want to thank Robert behind the scenes for making the webinar happen, and Marina as well for all the arrangements and getting a hold of Dr. Paul Hamor for this morning's conversation. And I have to say, I have known Dr. Hamor since he was a young boy, because I missed him for most of his years at Emanuel School, because I only got here in '89, so around the time that he was heading over to Sydney Grammar. But we did have the joy of learning together as he was becoming a bar mitzvah at Emanuel Synagogue, as well as leader, a madrich in Netzer. And so after his time through that, he then went on to Sydney University, where he got his bachelor's in science, up to the University of Queensland for his studies in medicine. And he worked mostly up in Queensland as an intern and resident before coming back for training at Royal Prince Alfred Hospital. And about 4 or 5 years ago, moving over to Prince of Wales Hospital. And in the meantime, he was fortunate to be able to meet the lovely Catherine Spire, also a doctor, and have 2 gorgeous girls who are members of the synagogue. And so it's wonderful to have someone who is so connected to Emanuel, but also to medicine. He is now the consultant respiratory and sleeping physician and a staff specialist at Prince of Wales, where he's especially of interest to us, involved in the planning and preparation of COVID-19 within the hospital system in a clinical, logistical, and workforce planning manner. And he's going to talk to us about what it's like dealing with COVID-19 from inside the hospital, and also then address a little bit, some of the upcoming issues regarding either treatments or vaccines, and the prognosis on those situations. And we'll have questions from all of you after that. So with great joy, I turn it over to Dr. Paul Hamor for this morning's discussion. Thanks, Paul.
Thank you very much. And I welcome to everyone, and thank you for having me. I'm so pleased to be here and report that we're in a far better position in Australia than I ever thought we would be. And it's made my job so much easier. So thank you to all of you for doing your jobs by staying at home and doing all the hard work so that my job is much easier. I hope that I can see there's about 70 people, or nearly 80 people online now. And I hope that we can have a bit more of a discussion rather than a pure lecture. So I think Rabbi Kamins is going to be the moderator, so feel free to type in questions. I've prepared a few slides, but I probably prefer to speak off the cuff. So I'll go through the slides first, but really if you have questions, feel free to ask them. And Rabbi Kamins, if any of them relate to what I'm speaking about, just pipe in and ask me, and we can go off on a tangent. So I'll try to share my screen. I have to change my privacy preferences, sorry. There we go. I can't do it unless I quit Zoom. Do you mind if I quickly log off and log back on, guys?
Go ahead and do that, and I'll explain. So Dr. Hamor is actually, the background there is not a false background. It's actually his hospital, his room's at the hospital. And so obviously there's security arrangements on his computer when he's logging in through the hospital system. So he'll be back to us in just a minute. In the meantime, there's no better opportunity for a word from our sponsor. I didn't look to see the names of the participants, but there's lots of opportunities that you'll hear from. If you got news of this, you can get news of our daily activities at the synagogue. We welcome Dr. Hamor back with the slides that he is going to speak to. Here we go.
Okay, can you see those slides now?
Yeah.
Great, thank you. Feel free to call me Paul. So I thought I'd just give a little overview of where we're at today. And this is sort of some of the things which I wanted to talk about. It was about 3 weeks ago, I think, when my wife volunteered me to do this talk. And at that time, the message which I wanted to get through to the community was really one about self-isolation and community strategies. Now, 3 weeks later, everyone's done that pretty well. So I probably don't need to go over that again. And I think a lot of it was covered last week. So what I thought I might do is sort of run through what are some of the symptoms of coronavirus. A lot of you have heard, but there's probably a lot of information which hasn't been as well described in the media, which I want to talk about. Some of the prevention strategies that we've got at our disposal and some possible treatment options that are being investigated at the moment. So these are the numbers where we stand today. So on March 16th, this is where we were. This was literally only 33 days ago. And you can see down the base here, this is Australia. And at that time, we only had about a bit under 400 cases at the time. What was worrying me at the time, and why I volunteered to do this talk, and why a lot of healthcare physicians were freaking out at the time, was our trajectory was exactly the same as China, Italy, Spain, France, the US, and the UK. And so if you can see this yellow line here and we plot that out, that was our trajectory that we were on at the time. And you can see at day 20, which would have been at the end of March, really, we would have been in a situation like Italy. And so that was scaring us all significantly. Thankfully, the government put in some measures and everyone has complied with them. And you can see by April 4, we had started to flatten the curve. Whereas all the other countries where we've seen so much devastation have just continued on their rise and rise and rise. And this is where we're at today. And you can see that our curve is now significantly flattened, but so have a lot of other countries, although they started their social distancing measures a lot later than us. So Spain, Italy, France, and even the United States is starting to bend the curve slightly compared to other nations. But Australia, to our credit, has done an amazing job in flattening the curve, but we can't be complacent. So this is the cumulative cases of what we've, of new cases. I downloaded this last night. And yesterday we had a bit over 50 cases in the country. And these are the cases by state, with the dark blue indicating overseas transmission, the light green indicating local but known transmission, and the light blue indicating transmission where we don't know where the person has got coronavirus from. And that's the most worrying thing that we really want to focus on in our healthcare community. Because if we don't know where it's come from, it means that there's spread within the community that we haven't quite detected or gone on top of yet. And that is a risk to everyone if it spreads unchecked. These are the confirmed cases by age group. And I suppose everyone says, oh, look, this is a disease that we only need to worry about in the elderly. That's not true, unfortunately. It affects all individuals of all age groups. And there are plenty of people in hospital who are under the age of 60. So it's really important that, yes, it does disproportionately affect the elderly, but it certainly affects young people as well. This is Australian New South Wales stats updated last night. So Australia's performed 406,000 cases. That's about 16,000 tests per million population in Australia. And that's 50% more than the United States has tested per head of population. So we're one of the leading countries in terms of the number of tests that we've performed. Out of those tests, we've detected 6,500 cases, of which just under 3,000 are in New South Wales. As of yesterday, there are 184 people admitted to hospitals in Australia, and 57 of them are in New South Wales. 55 of those are in ICU around the country, and 25 are in ICU in New South Wales, with our total deaths being 68, 27 in New South Wales. Now, you probably remember I was talking that first curve of where I thought we would be right now. I thought that the number of people that we had admitted in Australia, the figures that we had for Australia would be the figures just for Prince of Wales Hospital. I thought that Prince of Wales Hospital by this time in April would have 184 patients with COVID in the hospital and 55 patients in ICU, just in Prince of Wales Hospital. And you can see that's all of Australia. So we've done an amazing job. I can tell you today, the number of coronavirus patients who are in Prince of Wales Hospital today is 1, with no one in ICU. And we've not had a single person in ICU this whole time. And so in some ways, I feel like a bit of a fraud because I've actually looked after 0 patients with coronavirus in terms of a one-on-one caring for them, because you guys have done such an amazing job in flattening the curve. So I'm speaking from a position of real thankfulness to you that we haven't had to be in a situation like New York or Italy or the UK. These are the local data. And it's interesting that we haven't had that many admissions because our local health districts, our local government areas have the highest number of cases in the country. So Waverley, Sydney and Woollahra are ranked 1, 2 and 7th in the state for the number of total COVID cases. But more importantly, and this is really concerning, is that we also rank 1, 2 and 3 for the number of unknown sources of coronavirus who've been detected. So we don't know where they caught their coronavirus from. So Sydney had 30 cases, the Sydney local government area, then Waverley, then Randwick. Woollahra is a little bit further down. So that's a little bit more concerning. So how do we go from that, and how do we check that we don't have this grumbling level of infection going on in the background without us knowing? And the answer is we just really need to do a whole bunch more testing. So a lot of you have probably seen that Bondi Beach now has a mobile clinic set up in it. We've got a very active clinic here at Prince of Wales Hospital on the grounds here. And St Vincent's Hospital also has a fever clinic where you can go in and be tested. And it's very quick. I've been swabbed twice already because I had a little sore throat. I've got 2 kids at home. And as you know, if they're in daycare, they're bringing home viruses all the time. So probably over the last 12 months, I've had a respiratory virus every 2 to 4 weeks. So it wouldn't be unusual for me to have some sort of symptoms, but now I'm a lot more aware of it. I'm getting tested regularly. And actually, as a healthcare worker, it was essential I be tested. We now want everyone with symptoms to be tested often or as soon as you get symptoms. And it may be that your symptoms go away and different symptoms come back, you get tested again. And it's the only way we're really going to pick up cases where we haven't pick up any sort of grumbling background infection within the community. So that are the stats. Any questions, Rabbi Kamins, on the stats so far?
So
Sorry.
the questions, are not quite yet on the stats. There's some interesting questions to come about some of the things that you and I spoke about. But so those who have questions up, just hold on. We'll have Paul continue on through this a little bit, and then we'll come over to those questions.
Right. So I'll just talk a little bit about the coronavirus and what symptoms people might experience. So we've had coronaviruses in the community for decades. There's 4 very widely circulated coronaviruses which cause colds, a bit of a sniffle in most people, to be honest. If you had some underlying lung disease, it might cause you to be in hospital with a little bit of oxygen requirements, but really they were very, very minor illnesses. Apart from those 4 common cold type coronaviruses, there are 3 new ones which have been detected in the last 10 to 15 years. So SARS was first sort of detected in China and spread through Hong Kong, and there were little outbreaks around the world, including in Taiwan, South Korea, and Canada. And they were put under control by social distancing measures. It wasn't as easily transmissible as our current COVID crisis. There's also MERS, which was thought to come from camels. So MERS stands for Middle Eastern Respiratory Syndrome. That also had a small outbreak in South Korea. And now we've got the SARS-CoV-2 virus, which causes the disease which we call COVID-19. But there's hundreds of coronaviruses that circulate in animals. in bats, in camels, a whole bunch of animals. And at any time, these could mutate and jump to humans. And I suppose we always need to be aware that this could happen in any part of the world. And it's not just because it was a wet market in Wuhan, that probably increases the risk, but there are hundreds of coronaviruses that we always need to be aware of. In terms of pandemic planning, everyone thought the big next pandemic would be an influenza pandemic. And the reason for that is influenza mutates readily, and we share our influenza virus with birds and pigs, and they catch flu from us and we catch flu from them. And when there is a large, rather than a genetic drift, that is the slight mutations, there is a genetic shift, that is there's a massive jump in the genetic code that creates a new type of flu virus that we've never been exposed to. That's when we get a pandemic influenza. And that's what happened with the H1N1 flu of 2009. So in terms of preventative therapies, the biggest things that we can use in a pandemic situation are non-pharmacological intervention. And so these are the things that you've all been hearing. So active case detection and isolation, contact tracing and quarantine, travel restrictions, social distancing at first of at-risk groups, and then social distancing of an entire population, and encouraging healthy hygiene and habits. So making sure you wash your hands regularly, making sure that if you've got any respiratory symptoms, you don't leave the house blowing your nose with a handkerchief, putting it in your pocket and reusing the same handkerchief later. If you're sick and you've got symptoms, at the moment, you need to stay at home and at the moment, get tested as well. The other preventative therapies in a general sense, vaccination and prophylactic medications. So you know that in how vaccination programs work, we have them for measles, mumps, rubella, we have them for influenza. And
problem with the connection. We just had a little problem, Paul, with your connection, at least on this end. You've frozen. So haven't had technical difficulty yet. So hopefully he'll be able to come back. I'm going to send him a little message, or Rob, if you want to see if he is coming in. While that's going on, I will just let, because I don't think that you can all see what the questions are, but there's, based on where we're at, just the whole question of, have we done enough, and is it therefore time to loosen things and allow people out into the world, and what's that balance, and how does one strike it? And then there's some very sophisticated questions about the virus and similarities to other viruses as well. And then, and this is a question that Paul and I spoke about before, that we would talk about the whole issue of the app and the tracing. Okay, I can see that Paul's trying to come back.
Okay. Online, hopefully.
Yeah, you're back in.
I'm on the University of New South Wales internet, and they've kicked me off for some reason, but I'm linking from my mobile phone now, so hopefully that will be a bit stronger. So we're talking about vaccination measures, so an influenza vaccine. So influenza vaccines are partially effective. You've probably heard friends and family say, look, I got my influenza vaccine this year, but I still got the flu. So I see influenza vaccine as a bit like wearing a seatbelt rather than giving you complete protection like you might otherwise see from measles or polio or something like that. And part of that is because the influenza virus mutates so quickly. So even within a season, the flu virus that we see at the start of the season is different to the flu virus that we see at the end of the season because of this genetic drift. And that means giving complete protection very difficult. But what it does mean is that you're less likely to develop serious complications of the flu. So you're less likely to be admitted to hospital. You're less, if you do get it, you're more likely to have a shorter course of illness that might only last 3 or 4 days rather than putting you in bed for 2 weeks. So that's influenza vaccinations. It's unclear with coronaviruses what sort of vaccination we'd be able to get. Whether that would be something that you would need a yearly shot for, or whether you can have a one-off and you're protected for life. I suspect it'll probably be a bit more like the first, that you'd need regular injections, but it really depends on what sort of vaccine technology they're going to use. So I'll talk a little bit more about vaccination later, I think. Now, is my screen still sharing?
Yeah. Yes.
Okay. There we go.
Let's see. Not any. Wait, no, not seeing anything right now. Sorry, Paul.
Okay, let me just try bring that back up again.
Yeah, now it is again.
Okay, great.
And the questions are piling up, so that's good.
Good, good. Now, in terms of prophylactic medication, so I suppose the easiest way to think about prophylactic medications is 2 things that we use prophylactic medicines for already. So in HIV, people who might be at risk of exposure to HIV can take a medication called PrEP. So it's pre-exposure prophylaxis. And they take a small dose of an antiretroviral every day, and it prevents them from catching HIV if they get exposed to it. And the great thing about that is that it means that people who take the medication are less likely to contract HIV, and people who have HIV are being treated. And by doing that, we can really reduce the rates of HIV in the community. Another place that we use prophylactic medications is in genital herpes. So with antivirals there to stop those recurrent outbreaks. And by suppressing the virus, it means that people aren't having the discomfort of those sort of symptoms, but also it means that they're less likely to pass on the virus to other people. So those are the 2 big benefits of prophylactic medications. We don't have any targeted medications at the moment that we know of that work for coronaviruses, but we do have some potential targets that I'll talk about a little bit later. Now, there's a few problems with developing a vaccine. So a vaccination aims to stimulate your immune system to produce antibodies. But the big risk is that you might overprime the immune system. So there'd be a risk that if you give a vaccine, it might overstimulate it and you'd have a reaction to the vaccine. Or you prime it to the extent that the vaccine is okay, but when you actually catch the illness, the immune response is disproportional to the virus that you got. So the immune system is complicated. And so that's why, although there are a lot of vaccine targets which people are looking at the moment, they really do need rigorous testing before they're rolled out to a very large community. That is the whole world. Because there'd be a problem that if there was a significant side effect and you roll it out to 1 million people, that would be a big problem. And we already have enough problems with people not trusting vaccine programs. So it's important that we get it right. So at the moment, there's about 8 vaccines that I read that are already in development, and some are already underway in early clinical trials in animal models, but none, as I understand it, are yet in human models. So it takes a long time to get those clinical trials underway. But then to build up the scale to produce all those vaccines takes time too. So the Gates Foundation has actually agreed just to build some factories, not knowing what vaccine technology is going to be used, ready to produce vaccines as soon as they become familiar. Now, each of these vaccines have a different technology. So, for example, for influenza vaccines, they're grown inside chicken eggs. And one vaccine comes from one chicken egg. So you need millions of chicken eggs to be produced for this to happen. That's one technology. Other technologies use other techniques. And so Bill Gates and Melinda Gates have agreed just to build factories for all of the technologies, hoping that they'll probably waste $1 billion in building them, but one of them will be okay. And they'll be ready to go as soon as it comes out. There's also been a hypothesis, which you might have read, that some of the anti-tuberculosis vaccines, so that's the BCG vaccine, that most of people in Australia haven't had. If you're over the age of about 50, you might have had, might confer some immunity against the coronavirus. And that was taken on observation models that, that the countries which seem to be very affected by coronavirus didn't have a widespread BCG vaccination program, but those where it seemed to be more controlled, like Germany, did have an active BCG vaccination program for a lot of their population until recently. That's a theory that probably still needs to be tested, and some of those clinical trials are being undertaken in Australia at the moment.
There's another question just about, one of these ideas. So someone has heard that Plaquenil is perhaps provides protection. Is that just an urban myth, though, is the question?
It's not an urban myth, but I think that the studies which were in favour of Plaquenil or hydroxychloroquine are pretty flawed and needs a lot more evidence. And I'm actually going to talk about that in the treatment side rather than in the vaccine side, because it's not a vaccine, it's more a treatment for moderate to severe disease. So I wouldn't be advising people to rush out and go buy Plaquenil off the shelves and taking it when they're well. I don't think it'll have any benefits, and you'll get all the side effects of it instead.
And then there's a comment from Facebook that there are 2 vaccine trials underway in Melbourne and Brisbane for human models. So
that's true. That's true. So the University of Queensland, who developed the HPV vaccine, they're using some of the very similar technology to try to develop some vaccinations in that sense as well. And I think there's another group in Melbourne who had been funded by the CDC for development of a SARS vaccine when SARS was big about 10 years ago. But when SARS kind of died out, the funding was stopped, and so they never progressed to human trials, which is a real shame, because we would have been a lot more advanced in our vaccine development had those trials gone ahead. So vaccination is useful for the concept of herd immunity. And this has actually been crossing my Facebook feed and WhatsApp groups for the last 24 to 48 hours, because there's been a few articles suggesting that actually there's this baseline reservoir of immunity in the community where coronavirus has been that we never even knew about. Some of those data is flawed, and I'll explain why it's flawed. For herd immunity to work, you need about 60 to 80% of the population to be immune. And the only way you're really going to achieve that is with an adequate vaccination program. If you've got a disease like coronavirus or COVID-19 that has a significant morbidity and mortality rate, it would be unacceptable to me to allow the virus to run uncontrolled in the population with the aim to achieve herd immunity. The number of deaths it would cause to me as a healthcare worker would be unacceptable.
Paul, I want to thank you for that. It's interesting because Mary Lou last week spoke about that as well. That which I hope that from a spiritual community, that ethical and moral question of allowing, a large percentage of the population to die so that you could create this herd immunity is not acceptable from certain ethical and moral perceptions. So yeah, I just wanted to pipe in on that one.
That's right. I mean, I think it's interesting for us to, because there's a lot of people who are saying we need to accept that we're going to lose loss of life in this, and we should just let it run its course. And it's not that much worse than the flu. So let me just try to dispel some of those things. If we think about the recent bushfires, right, which devastated the country, right? 31 people lost their lives. And each of those lives was an absolute tragedy. And the country mourned for those 31 people and thought this is a disaster, an absolute disaster. In Australia today, we've lost nearly 60 people, and people are going, oh, 60 people have died. It's not that many. That disconnect doesn't gel with me. You know, just because it's a virus doesn't make the loss of life any more justified. So that's my thoughts on our concept of death within this pandemic. I read an article that someone sent to me on WhatsApp last night that said there was a study that was published in The Guardian yesterday where in Santa Clara, which is I think an LA county, they did some studies looking at people's antibodies. And this is the thought that there's this undetected rate of infection in the community. And we just need to pick that up with antibody testing to see what the true rate of immunity in the population is. And they found in this study that it was 85 times more prevalent in the community than the number of cases. But they've extrapolated that from a small sample of people that they tested. But they've extrapolated there's 85 times their case numbers. So in Santa Clara County, it has 2 million people in Santa Clara County, and they've had 1,094 confirmed by nasal probe detection, 1,094 cases of coronavirus with 50 deaths. And they're suggesting that somewhere between 48,000 and 81,000 people are actually infected out of 2 million people. To me, that's not herd immunity. And they've had 50 people die to get that. Okay, so they're suggesting that the death rate is actually closer to 0.12 to 0.2% of the population, rather than 4 to 8%, which we're seeing in Italy. And I agree that 4 to 8% death rate in Italy and in New York is probably more of a reflection that they're not enough cases, particularly the mild cases. In Australia, I'm pretty confident we're picking up and trying to pick up as many of the mild cases as we have, because we have the best testing regimen in the world. But just to sort of contrast it a little bit, so they say that it might have a death rate of 0.12 to 0.2. So in New York City at the moment, and I'll show you, I'll see if I can get the slide up. So this is the total number of cases in the world, 2,300,000. And in the US, in the US, there's been 732,000 cases. And in New York, there's been 13,000 deaths in New York City. And I assume that that's the 5 boroughs. Now, when I Googled it, there are 8 million people in New York City. So this represents a death rate of 0.16% of New York, not of cases, of New York. To me, that's unacceptable. That 0.16 of an entire population have just been wiped out. So this is where we're talking about the numbers and things like that. If we go and talk about real death rates, if we're looking at extrapolating this over a whole population, we know that this is at least has a death rate of 0.16, assuming all of New York has coronavirus right now. And we know that they don't. So I'm guessing that the true death rate is about 0.5. A normal flu is probably less than 0.1%. Okay, so we're dealing with a deadly virus. And I'll probably stop talking about deaths now because I think I've rammed home the point enough. But this idea that we can get herd immunity without significant death and morbidity is false. And this concept is really only going to be achievable with a vaccine. The other thing is, and we don't know this, is how fast the coronavirus may mutate in time and whether people can catch coronavirus again after they've already had it. We know with the normal coronaviruses that we have, the 4 that just cause colds, we can catch them again probably in 2 or 3 years after we've had a coronavirus. So our immunity may wane over time. So there are 2 things that allow us to catch viruses again. Either our immunity wanes or the virus mutates, or a combination of the 2. And because COVID-19 has been around for long enough, we don't know which of those two things will happen in coronavirus. I'm going to move on and just talk about symptoms now, and then we might move to questions at the end. Because at the moment, the message which I want to give to the community is if you've got any symptoms, it's best you go get tested. Wallara, Waverley and Randwick have the highest levels of undetected cases in the country. And so we need to be very aware of what symptoms we're feeling and get tested early. The testing's easy. You have a probe which is smaller than a piece of pen. It looks more like a cotton bud, and the cotton bud gets pushed down the back of your nose until it tickles really the very, very back of your throat through your nose. It's not comfortable, but if it's not uncomfortable, that they haven't done it properly, to be honest. And they'll also get a swab from the back of your throat. You should get tested if you have any respiratory or cold-like symptoms with or without a fever, okay? And those symptoms are cough, sore throat, runny nose, loss of smell, and fever. And I'm going to talk a bit more about loss of smell. And then there's these other constitutional symptoms which people might not otherwise think about. But at the moment, I'd encourage you to even get testing for these things if you have them. They are headache, if you're not a person who usually gets headaches, fatigue, malaise, and muscle aches. Okay. Now, if you get diagnosed, so if your swab ends up being positive, you'll be called by the hospital and they'll give you your result. You'll need to strictly isolate for a minimum of 10 days and or the resolution of symptoms for 72 hours. So if your symptoms go away after 2 days, you need to stay isolated for the full 10 days. If at the end of 10 days you still have symptoms, you've still got to keep on isolating until all your symptoms have gone for at least 3 days.
Now, if you get a test because you have symptoms, should you actually isolate while you're waiting for the results on the assumption that you could be positive, or should you stay out in the public arena?
No, thank you, Rabbi. It's a great question. If you get the test, you should assume you're positive until such time that you get the all clear. Okay? So I know that's annoying because people go, oh, I don't want to self-isolate from my family until I get the results. People are getting the results within 24 to 48 hours now. It's relatively quick. But you're going because you want to exclude coronavirus. You can't go out and then go get your test and then go do the shopping. That wouldn't make sense because you're going because you're worried you've got coronavirus. So please, if you get the coronavirus test, you go get your test and go home and strictly isolate. And there's guidelines on the New South Wales Health website on what it means to strictly isolate, particularly if you're sharing the house with other family members or housemates. So if you do turn out to be positive, you'll also be called by the public health investigation team, and they'll do what's called contact tracing. They want to figure out who you got it from and if they can put that together. They also will want to know where you've been all the time that you've had symptoms, and including 1 or 2 days before you got symptoms, in case you had some asymptomatic spread.
I wonder if you might want to, that could be a good segue because that question is out there and you and I spoke about it. Talk about, the app that will help with contact tracing. I don't know if this is a good point to address that.
Actually, can we talk about it at the end? Because it's the app to help with that is probably complex. Yeah. But essentially, just to give why the app is important, and we can talk about the app in detail later, is the Public Health Authority wants to know where you've been and who you've been in contact with since the time that you caught the coronavirus, if they can figure that out, or at least for 2 days before you've started showing symptoms. And at the moment, they're relying on people's memory and goodwill to try and tell them where they've been. And you can probably remember at the moment, because you're all isolated and socially distant, that you've probably not had very many contacts with many people over the last 5 days. So the contact tracing is very easy. But what happens if you went to the shops and you did some shopping and you used aisle number 2 in the supermarket to put all your stuff on, and then a 70-year-old grandma follows after you and puts all her stuff on the trolley, touches the pin pad because it was over $200 for the transaction. She was buying a lot of toilet paper, and she caught coronavirus. How are the two of you going to link? Because you've never met her, she's never met you. And that's where these apps are hoped will join dots together and allow us to contact trace in a way that we've never been able to do before. So I'll talk about the apps perhaps a little bit later. The other thing which will be done is you'll be enrolled in a sort of an out-of-hospital program where people from the hospital will call you every 1 to 3 days to check on your progress until your symptoms recover. And they're the ones who will give you clearance to stop your self-isolation. So you don't need to worry about the 10 days or resolution symptoms. You don't need to worry about that or remember it, because the hospital staff will tell you when it's safe for you to release your self-quarantine. One of the trials which we're doing at the moment at Prince Wales Hospital, and we're building the app at the moment, is we want to give people who are diagnosed with coronavirus a little oxygen meter to put on their finger, and we'll ask them to download an app onto their phone, and I'll just bring up the app now, and it'll just ask them how they're feeling. They'll ask for their measurements, and it'll allow us to monitor your oxygen levels and your symptoms remotely. And when we were building this app, we were building it with a presumption that we'd be managing 2,000 to 3,000 people in the community at any one time. So it's got a big dashboard to monitor everyone. And that will give you the confidence and reassurance that we're looking over a lot of the symptoms and the measurements that you're taking. And if anything is looking astray, we'll ask you to come into hospital and be checked out. So that's what happens if you're diagnosed. These are the symptoms of mild disease. So all of the top ones you probably know about: cough, fever, fatigue, shortness of breath, and other respiratory symptoms are mostly common. What's less commonly said in the media is some gastrointestinal symptoms. So loss of appetite, nausea, vomiting, diarrhea. Those symptoms can also be the only symptoms that people have. And I haven't put it on this slide, but those other symptoms I mentioned previously, so headache, muscle aches, and overwhelming fatigue are also symptoms that you should be aware about. But interestingly, and this has really only come out in the last 3 weeks or so, is profound loss of smell and loss of taste seems to affect particularly milder disease and younger people in 30 to 50% of cases. And this isn't a bit of a sniff. I can't, I'm not smelling the food as well as I used to. This is a sudden absence of smell or taste. And to the point where people, because a colleague of mine is an ear, nose and throat surgeon, and he had several people presenting to him with thinking that it was problems with their sinuses because they suddenly couldn't smell. And they went off and got tested. They'd returned from Aspen after a ski holiday, and they ended up being positive for coronavirus. So loss of smell and loss of taste is an interesting one, and it's probably not mentioned in the media much. So if you have any of these other symptoms and you've got loss of smell or taste, that increases the chances you might have, that the symptoms might be related to coronavirus. This is disease progression, and this is important for me because it gives me an idea to predict when people are going to deteriorate. So and this comes from an article from China, published by Zhu et al., where he looked at the symptom progression of I think he looked at about 50,000 people and what their symptoms were over time. And for the most part, the first week is pretty cruisy. Most people have fever, a bit of cough, they feel unwell. And then as you know, the bulk of people recover in that period. For those who are going to progress and deteriorate, they start to become short of breath and develop low oxygen levels around the day 7 to day 9 mark. And so for me, observing people in the community, who are known to have coronavirus, they're the really days that I want to be aware what's going on in their day-to-day life and if they develop symptoms. So if that happens, they come into hospital, and if they've got low oxygen levels, we'll put them on oxygen. Then for those who might have comorbidities, other health issues, or are just unlucky and they have a more advanced disease, and that's less than 5% of people who are diagnosed with coronavirus, they usually progress to requiring ventilation on a machine to help them breathe at about the day 9, day 10 mark. So that's the sort of time frame that we're looking at. So what's moderate disease? So moderate disease usually need hospitalization. You have low blood oxygen levels, and we usually give you some oxygen just by some nasal prongs to keep your oxygen levels up. And we do some regular blood tests and monitoring in the hospital just to check you're okay. So, to be honest, for the most patients that we've had in hospital here at Prince of Wales, we've just given them a litre or two of oxygen via nasal prongs, and we've watched them for a week or two to make sure that they recover. And when they've recovered, we send them home. So it hasn't been a particularly concerning illness from that point of view. And for the most part, people are sitting in bed on their phones, on their computers. They're not feeling particularly unwell, but their oxygen levels are a little bit lower than they should be. But it's pretty lonely because you're isolated, you're probably a bit bored in hospital. The nurses and doctors can't spend significant amounts of time in with you, and you're not allowed to have any visitors because of the risk that they could catch coronavirus off you. And also we don't want personal protective equipment being used unnecessarily unless it's for a healthcare worker. So if you are diagnosed with coronavirus in the community and you've been told to come into hospital, make sure you bring your phone and your charger, bring a computer, bring some books and magazines and puzzles, because you might be in hospital for a week or so, and it's pretty boring. The likelihood is you won't be particularly sick, but you'll be bored more than feeling sick. Severe disease is what we're all concerned about, and why the national stockpiles of ventilators have increased and all that sort of thing. So patients require a lot of increased oxygen support in this period of illness. So much so that when they require so much oxygen, we require to put down a breathing tube to help them breathe and give them very high levels of oxygen. As a general rule though, the breathing tube is not particularly helpful in the larger scheme of things. The reason for that is when we breathe, our chest expands and air gets sucked into our chest. But with a breathing tube, we push air into the lungs. We blow them up like balloons. And that means that the pressure and dynamics of how the lungs work is very different. And when you're dealing with a lung which is already quite friable and delicate because it's got a virus in there, it can actually cause a bit of damage before it does any benefit. So we often find that when we intubate people, in the first instance, it's quite rocky, the sort of progress that we make for the first few hours and first few days. So as a general rule, we'll be trying to avoid intubation as much as possible. Despite all this focus on ventilators, we're going to be trying to manage people on the ward as much as we can. And so I suppose if you're coming in a hospital and you're diagnosed with coronavirus, be aware that we're probably going to try to keep you on the ward for as long as possible and only intubate you as a last resort. Potential treatments. Look, I'll run through these quickly because people have probably asked a lot of questions about them.
Yes.
So these are the 5 ones which probably hold or are being thought of as holding the most promise. I haven't listed things which have been disproven or are thought not to offer promise. Hydroxychloroquine is a medication that is used in rheumatic conditions and autoimmune conditions. The other name of it is Plaquenil. The mechanism of how it works on the virus is that it may reduce viral entry into cells. It's thought it seems to at least work in the test tube. Where people became really excited about hydroxychloroquine was a French study which came out about 4 to 6 weeks ago. They only had 10 or 20 patients in the study, very low numbers, and they gave them hydroxychloroquine, and then they measured them with swabs to see whether they could still detect virus on the swabs. And they found that after a week, people who were taking hydroxychloroquine, fewer of those patients were, the disease was detectable on a nasal swab. And that was really the outcome measure. There were a few problems. And since that article's come out, it's actually been retracted and rejected by the journal because of methodological flaws. But they excluded people who they'd put on hydroxychloroquine from their final analysis because they either ended up being intubated or became worse. But to be honest, it's really important to keep those people in your study, because or else if you're only analysing the people who do well, you're really just reinforcing what your hypothesis was. So there were some methodological issues there. The second issue was that people were, the outcome measure was probably wrong. So when we do this swab in the nose, we don't think it's a very good way to assess whether you're being treated or improving with the disease or not. A better outcome measure would be to say, well, how many people progressed with their oxygen requirements? How many people needed to be intubated despite having hydroxychloroquine? How many people got out of hospital quicker because they were taking hydroxychloroquine? None of those measurements were made. And so the article was withdrawn recently, and actually 2 or 3 weeks later, another French group repeated the study with very similar methodology and found that the nasal swabs weren't particularly changed in their pickup rate of the virus, which refuted the first study. So I think it's been approved by the FDA for use, but I don't think it's a panacea. I don't think that it's, it may have some use at a population level, but we really need to consider that this is a very experimental therapy. It hasn't been proven in humans yet. Some people might say, why don't we just give it a go and see if it works? There's a few reasons. Number one, there's not enough hydroxychloroquine in the world to go around at the moment because there really wasn't much use for it before the pandemic started. The second thing is it has a bunch of side effects, and you don't want to give people the side effects unless they're going to receive any benefit from the drug. So that's hydroxychloroquine. Remdesivir was an antiviral medication that was developed initially for Ebola. And it looks to reduce the replication rate of the virus in the cells and hopefully treat it. Now, they've recently published a paper which was in the New England Journal of Medicine, which interestingly had more authors than patients in the study. And they had about 51 patients in the study. I think there were 55 authors on the study. And they looked, there was no control group, and their outcomes were wishy-washy, but the sort of outcomes which we would want to look at, that is how many people progressed to intensive care, how many people just stayed on oxygen, how many people might have got off oxygen more quickly. So that was good. But without having a control group in those same hospitals, you can't tell whether it was all the other things that those hospitals were doing or whether it was the remdesivir that was doing it. And that's the big flaw in the study. That study, which was published in the New England Journal of Medicine, I think raises more questions than answers, which is good. It means we can test them. And a study that's coming out soon is going to be looking at 3,000 to 4,000 people who are being treated with remdesivir rather than just 50. But again, unfortunately, is not going to have a control group. Now, if this was a perfect antiviral medication, we should see viral replication stop as soon as you start taking the medication. We should see viral loads plummet, And we should see a reduction in people going to ICU or having increasing oxygen requirements. And that wasn't seen in those first 50 patients. It definitely wasn't a cure. It might help a little bit, but how much we still don't know yet. And certainly because it's a brand new drug, it hasn't been ramped up to a scale where we can be offering it at a population scale to treat coronavirus. Convalescent sera is probably where I see the most hope of some treatment for severe disease. So what this is you take people who've had coronavirus and have recovered, and they therefore have antibodies in their blood. So you get those people to give a blood transfusion, you spin off and take away all the blood cells, and you're just left with plasma and all the antibodies that they've had in their system. And you give that plasma to someone who's really sick, who probably hasn't developed antibodies themselves yet. And those antibodies that are in the donated serum help fight the virus. So this practice isn't widespread at the moment and still undergoing some testing. But to me, that's probably for me, from a first principles point of view, probably the most likely treatment we've got at the moment, but we've got no large-scale trials to prove that yet. The fourth is IVIG, that's intravenous immunoglobulins. That's similar to convalescent sera, but it's not taking it specifically from people who've had coronavirus. And in the studies that came out from China, every single patient who was given IVIG died. But to be honest, they're probably giving them to the most sick patients to start with. So it's hard to say whether it would work or would not work. So probably we need more time to evaluate that. The last is anticoagulants. So one thing that's been picked up is that in very severe disease, the blood of patients who have coronavirus is probably thicker than usual, and it tends to clot more easily. And that's causing problems with blood flow through the lungs because the blood is so thick. And so the thought is by giving some blood thinners that we might be able to help reverse some of that process, some of the side effects of, I suppose, the fight that the body's been having with coronavirus. Those are still in early stages, but when we look at the markers of blood clots in the body, in some patients with very severe disease, they're very, very elevated. And so a lot of institutions overseas are starting to introduce anticoagulants, and some more definitive trials will come out in the coming weeks and months. I thought I'd end with what it's like for healthcare workers at Prince of Wales right now. And it's been an emotional journey for all of us. As I started the talk, I told you in mid-March, we were all needing a lot of toilet paper because we were pretty worried about what was coming. And that hasn't eventuated. Seeing our colleagues in Italy and before that in China, what they went through, which was where we were in mid-March, caused a lot of anxiety for healthcare workers and people in the front line. We are overjoyed by the response from the Australian public in self-isolation, and we're so thankful for what's happened. I know in Italy and in the UK, and I think some places in the US as well, they come out at 6 o'clock in the evening and they clap the healthcare workers. We should come out at 6 p.m. and clap the epidemiologists and the scientists that advise the government, because they're the ones that have saved us, really. So I'm really happy. What you've done by staying at home has bought us time. The amount of change that has gone on in the hospital over the last month is huge. We've had to rewrite policies, change the way that we do things, rethink about even how we transport a patient from the emergency department to the ward. We need to rethink what lift do they take, things like that. You've given us time for us to do simulations, to have drills, to get ready for PPE, to create dedicated intubation teams that they can comfortably intubate the patient and not worry that they're going to catch COVID themselves. We've changed the number of rooms that we have. So we have many more single rooms than we ever did. And we've now started to increase our ventilator capacity as well. So we've had huge, enormous change within the hospital. And that's all thanks to you, that we've had time to do that. If we hadn't done those things, we would have been caught unprepared. And so I feel comfortable now that we could, and hopefully we won't need to, but we could deal with something if we needed to. And I've already talked about the number of cases in the hospital and how busy we are. I would say though, as a healthcare worker, I feel pretty lucky in society. There have been a lot of institutions that have been doing a lot of favors for healthcare workers, and it's greatly appreciated. Often healthcare workers at work, we get yelled at, spat at, you know, sometimes treated in awful ways. And as a society, well, through government, we're pretty under-resourced for the sort of work that we do. But despite being under-resourced, I think we provide a pretty good service. And it's nice that, that society has shown their gratitude for the work we do. But we're not doing much at the moment. The hospital's not very busy. Probably the hospital is half empty at the moment, waiting for cases. There's no elective surgery going on. A lot of my junior doctors are sitting around having long lunches. So things are easy for us. And we're lucky in society because we've kept our jobs. We're still getting paid. We get to come to work. We socialize with a whole bunch of people talking because we're in a work environment. We're talking. And that compares starkly to a whole bunch of people who are at home, who have lost their jobs, who are isolated, don't get to talk to anyone. And so I've seen a few things on social media, and it happens at other hospitals and the like, where companies have been delivering prepared food packages and relief packages for the healthcare workers at hospitals. One hospital had a delivery of 400 meals for the healthcare workers to thank them. And it's really nice, and it's an amazing gesture. But actually, what I'd really like us to think about is not the healthcare workers who are in a privileged position in jobs, but the people who've lost their jobs, who can't afford to put meals on the table, who really need our help at the moment. And they're the ones who can't really get their message out because they're isolated at home. So all of us need to think about how we can really support those people over the next month to 6 months during this crisis. So that's all I want to say. So thank you, but direct those efforts elsewhere would be also very good as a society. Let's take some questions.
Yeah, that is awesome, Paul, because that leads then to, one thrust of the question is, okay, so we've done such a great job flattening the curve. When is it going to be the time to do two things? One, to allow certain elective surgeries to come back to hospitals, especially those that are dealing with heart issues and cancer issues and things like that. And the other is, and when do we start like reopening restaurants for limited seating or allow these kinds of things to happen? How does one strike the balance between the healthcare profession, the epidemiologists, the scientists offering that device, let alone those pushing for the economy to be open?
Yeah. So two separate things, I'll answer them separately. The first is about elective surgery and when we get the rest of the normal healthcare things going. So I had a slide on that. Oh, it was just a title. Healthcare for the most part is still open. GPs are still open. It's really important that if you have symptoms of illness, that you seek medical attention. If you're peeing blood, you've got to see a urologist. If you've got abdominal pain, you need to speak to your GP. If you've got mental health problems, you still need to talk to your GP. These things are still going on. And one of the things which the government has done, which is great, is allowed doctors to have rebates for providing telephone consultations, which wasn't allowed before. And so it's important that you still access healthcare. Just because we're in a pandemic doesn't mean that breast cancers don't go ahead, that people won't won't progress with their cancers, won't have strokes or heart attacks. Those things will still go ahead. And what I'm concerned about and what we're concerned about in the hospital is that more people are going to die in this pandemic in Australia from a reluctance to seek medical care for serious things than from the pandemic itself, if we've done such a good job at flattening the curve. So I urge you that if you do have health problems, that you still stay engaged in the healthcare system. Now, for elective surgery, the biggest problem with elective surgery was that they use a lot of PPE themselves on a day-to-day basis. And part of the problem with that is that they would need to be changed, and that might have taken away from the PPE supplies that we needed to prepare and care for patients with COVID-19. The other concern at the moment is about the unknown, those people who might be in the community with asymptomatic COVID, who might just come in for their knee replacement. And what does that mean if they come in and they're intubated for their knee replacement, for their surgery, and then suddenly the whole theatre comes down with coronavirus, and they're seeing patients on a daily basis, and then they spread them. So these are some of the issues which we're working through in the hospital, and how we tackle those issues is complex. But what I would say is that the more and more we suppress the number of people in the community with coronavirus, the easier it will be to open up things like surgery, because we can be more reassured that the pre-test, that the chances you've got coronavirus when you walk in for your knee replacement, or probably wheeled in for your knee replacement, is going to be small. So that's where the opening for surgery. I would imagine there will be an easing off on the ban on elective surgery in the coming week, to try get a few of the cases moving, because otherwise we're going to have a backlog of things. And we've had 3 weeks now where all the surgeons and all the anaesthetists have actually been doing drills on how to prepare to do surgery in patients with coronavirus. So they're ready now. So now we can start to get some business up and running with that. The second question was about social distancing and easing off on social distancing. I'm a bit more pessimistic about this, and I think what ScoMo said about being locked up or socially distant for another 4 weeks is probably true. Until we get to a point where the number of cases who we can find no known contact trace of reduces to the point, and almost all of the new cases of coronavirus we can link to another case. If we get to that point, then I'd feel a lot more comfortable. The reason why I'm more pessimistic is this case in Nepean, which some people have read about. So a healthcare worker who was working at some aged care homes in Nepean had a scratchy throat. She didn't think much of it. I don't know if she had kids or not, but it was a minimal symptom. She went to work, and I think she worked at 3 different aged care facilities and helped with those people. About 5 days after she'd sort of had a scratchy throat, she thought, I should probably get tested, because it is a bit weird and they're telling healthcare workers to get tested. So she got tested and she was positive. Now, out of that one case, there's been 20 to 30 people diagnosed. Now, because we've got social distancing at the moment, we've been able to contain that to 20 to 30 people, which is great. But if we didn't have social distancing, what if that one person who had the scratchy throat hopped on the train from her home in the inner west to go to Nepean, sat in a crowded train, went to dinner with her friends, went out on the weekend to a sporting event? Then we'd have massive spread of the disease that we wouldn't really be able to control. So that's my concern about the social distancing. And this probably goes to where the app might be useful. And so this will be a balance between, and so this is the surveillance app, which people seem to have some concerns about, which I'm probably fairly supportive of. So it's about balancing social restrictions against your individual restrictions, I suppose. So with the app, if this nurse had the app turned on and we weren't in a socially distancing thing, and she was subsequently turned positive, the app would be able to say, right, she was on a train with these people, and these people were within 10 meters of her. I'm going to push a message to those 10 people, even though she's never met them and they've never met her. Send a message to those 10 people to, 1, get tested if you've got symptoms, and 2, you should probably go inside for 2 weeks and be even more socially distant. If we had that ability to do that, we would really be able to lock down on this virus and stop it from spreading. Remember, the virus doesn't want to cause sickness. The virus's sole purpose is to replicate, to find other people to inhabit, host, replicate, and spread. It's its goal in life. And so if we deny it the opportunity to find other people to infect, to spread it, and if we're able to clamp down on those people who might have had access to those, it means that 99% of the population can get on with their work, and the 1% who might have had a remote contact with a case would need to stay inside. And to me, that from a society is probably a great step forward in opening up the economy and allowing us to move forward, rather than using a very broad brush approach to the economy, which is everyone needs to stay inside. Does that answer the question, Rabbi?
I think so, yeah. Thank you. And here's a question just about, that takes us back to something earlier and just could perhaps give us some more sleepless nights. You mentioned how many coronaviruses there are in the animal population. How is it that only a few of them so far have escaped into the human? And, you know, what is the likelihood that more of these viruses, as actually Mary Lou spoke about last week, the human population encroaches more and more on the animal population, that we may be seeing more and more of these kinds of things, not every 100 years or every 10 years, but every year?
Yeah. So viruses mutate as a normal part of their life cycle. They don't have good check mechanisms to check that their replication is an exact copy of the one before it. So mutations happen fairly frequently. Why are hundreds of those coronaviruses not infective to humans? Viruses have co-evolved with the animals that they infect to find pathways within those organisms to infect them. And so although we share a lot of DNA with animals, the way that humans work in terms of, our biochemistry and the chemicals that we have and the receptors that we have are still pretty unique to humans compared to animals. And so viruses that try to jump often don't find an accepting host. It's sort of a seed and soil type approach. You might have a seed, but it doesn't find a fertile soil to land and grow. Now, it could be just due to random mutations that a virus mutates to a point that when it does jump a species, it is able to live and replicate within that new environment due to a random mutation. And that's essentially what happens with these coronaviruses when they happen, and similar to other viruses as well. So the chances of that happening is a random event. Is it happening more because we're encroaching on animals? To be honest, I think it would probably be happening less because we're not living surrounded by animals. When we move into animals' environments, we generally destroy it and don't live amongst animals. It's really with close contact with animals, that a very, very close contact, that this can jump. And so with the markets in Wuhan, they've got a whole raft of animals that are there. So it creates the potential for a virus from there to jump. But you could say a very similar thing about people who are living in Africa and living in amongst animals within Africa and eating the fruits of the forest there. So I think it's going to be a random thing. What we do see from time to time is that a virus might mutate and allow transmission to a human, but that virus isn't able to to be transferred from human to human. And so you might have heard of human to human transmission being an important factor of virus infectivity. So about 5 years ago, or sometime in the last decade, there was some bird flu viruses where birds in China were infecting humans. But those flus could never infect anyone person to person. It was always bird to person.
And I think that's what they said at first about this in China, was that they weren't noticing human to human, transfer at first. I think.
Well, that's what they thought was happening, but I think that was probably a false thing. But certainly, because chickens are such a huge staple food for the whole world, bird to human transmission is very likely that we would have a pandemic based on a bird flu. And in fact, in most of the pandemic modeling that was done before this happened, all countries in theory were told to prepare for a pandemic. And they were doing modeling on a 75% mortality rate with flu. And so when this came along, they went, oh, it's nothing. It's only got a 0.1 or 1% mortality rate. It's way better than the models which we were predicting, which is part of the reason why the UK went down the herd immunity thing until they shifted course pretty late, because they were expecting a flu with 75% mortality. What makes this virus deadly and why it's so widespread is it's a very efficient virus. It's a successful virus because it spreads amongst people who are not sick. If you look at Ebola, the reason why Ebola is a deadly virus, it's awful if you get it. But the reason why it never reached pandemic potential is because by the time you're very infective, you're really sick and you find it difficult to go out and do things. But if you're not sick, but are still shedding the virus, that creates huge pandemic potential. And that's what happened with COVID-19. There is no reason why in 12 months' time, we won't see another random mutation of a flu and have a whole different pandemic. Because it's like playing roulette, If it lands on number 33 on the roulette table, people still bet on number 33 next time because it's just as likely to come up in the next spin as this spin. So we shouldn't feel complacent at the end of this pandemic that this is our 1 in 100 year pandemic. All these viruses have the potential to become pandemic at any time, and we always need to be wary of that.
Thank you for that. There's a question that is dealing with, the notion that there could be false negatives, and especially with mild symptoms. I'm just thinking about that question about elective surgery. Might there be the thing that you would test a patient, knowing that they're going to be coming into surgery for a week, just give them a test, and then even though there's no symptoms, but just because of the risk of bringing them into the hospital system and using that machinery, have a test, and even 5 days later, another test. That's one hand. And then on the other hand, if someone tests negative but has symptoms, should they have a second test within a few days' time?
So it's a good question. So to answer the first one first, I suppose we're still moving through the machinery of whether we should be pre-testing people before they have surgery. At the moment, the chances that you've got coronavirus in the community is still very low. So in New South Wales, yesterday, I think 17 people were diagnosed with coronavirus out of 5 or 6 million people in the state. So the chances that you're coming and you're asymptomatic and you're coming for a routine operation is probably going to be really low. And we're lucky, and that's because we flattened the curve. That said, if you've been on the waiting list for 2 years for a knee operation and you've been called up, there's a good proportion of people who will not report their runny nose or their itchy throat because they really just want to get that surgery. And it's unlikely that I've got coronavirus because it's not that prevalent. So there is a case to be made for testing everyone. We're still working through the logistics of that at the moment. And I don't know where we're going to land on that question. The second part of the question was about false negatives. So when we think about tests, or when a doctor thinks about tests, they think of it before they even do the test. What are the chances you've got coronavirus? We call that the pre-test probability. And then we add the test in to it. That's the test. And then we look at the two together. So let's say you had symptoms. So you had a runny nose, sore throat, you had lost your sense of smell, and you got you had contact with a person who had known coronavirus a week ago, we'd say your pretest probability is relatively high. Now, if we did the swab and the swab was negative, I probably wouldn't believe it and would do it again. But at the moment, because the amount of coronavirus in the community is low, if you haven't had any close contacts with someone with coronavirus, and your symptoms are relatively mild, and the test is negative, because your pretest probability is low and the test is negative, we'd probably accept that result. So we try to piece together both the symptoms and the test together. It's never in isolation. And so a negative swab, I agree, doesn't mean the person's negative. I'm at work at the moment. I was on call last night. I had a patient who was tested negative. I've swabbed him again this morning just to be sure. So.
Now, if you're able to look in the chat, I sent you a question through there because it was a very technical one. You might want to just stop the screen sharing so that, we can see you bigger anyway.
There.
But there are a few medical people out there and people.
Yeah, so who's that? So which question is it, from anonymous attendee or?
It's one that I sent. Yeah, I just cut and paste and sent it to you. So it should be,
okay.
Yeah, it's quite lengthy. I can.
Unless are you the anonymous attendee?
Yeah. You know what? I think it. Let's see if I can recreate it. Hold on one second. And here we go. So of the, you went through the issue about the trial drugs, but here, what is being done about the similarities between COVID and HAPE Diamex trialing and red cell transfusions for the hema iron dissociation? So that was one of the.
Oh, hemoglobin.
Yeah, and so I assume that's that, and then these are something further on about colchicine and things like that. They're all from a similar person.
Okay. Hang on. Oh, I think I've got the questions now. Sorry, I opened up the Q&A rather than the questions. Well, look, let me talk a little bit about the hemoglobin story first, because I found that quite interesting. I saw it come across my Facebook too. So one of the questions, a Diamox trial, what about red cell transfusion? Okay. For heme iron, is it? Okay, got it. So I've tried to actually look at some of the data for the hemoglobinopathies that have been suggested you might get with coronavirus. And I haven't actually found really good substantiated evidence that this is occurring. Although people's observation, I think, raises the question that there's something happening there. But can I prove that that's going on or suggest it? I don't know at the moment. So essentially for players at home, what I'm talking about is red blood cells carry oxygen around the body. Within the red cell, there's a molecule called hemoglobin. And hemoglobin at the center of it has an iron molecule, IRON, like in rust, okay? And that iron molecule grabs oxygen and holds it tight, picks it up at the lungs, and then delivers it to the tissues peripherally, and then comes back empty-handed, goes back to the lungs and gets more oxygen and grabs it. One of the theories with coronavirus is that it was affecting the way that the hemoglobin molecule worked, and that the iron itself was being changed to a different type of form that made it less able to carry oxygen. And this might explain some of the things that you might have heard online, that people with coronavirus look more like an altitude sickness rather than people with ARDS or a viral pneumonia. I think it's an interesting question, but I haven't seen the pathophysiology data to back up the claim. But it's certainly something that I think is worth pursuing, but I haven't seen the hard science about it.
And I imagine there's people pursuing that on. Another question is dealing with how in certain countries they're now requiring people, even though they're not necessarily so effective, to wear masks or even double bandanas with the weaves going different ways. But we haven't really gone to that place here yet. Why is Australia not doing that when it's leading, let's say, in social distancing, closing borders, and of course, also having so many tests available?
Yeah, I think the masks issue is really interesting. It's growing on me, the idea of masks, but I think there are two big issues. The first is if people went out and bought surgical masks or even N95 masks, that's actually less for me to use in the hospital. We've got probably enough PPE, but we don't have bucket loads of masks in the hospital to waste. In fact, and this is part of the issue with the elective surgery lists, that if all of them were using a mask, an N95 mask for the hospital, we would run out of N95 masks within a few weeks. And that's just within the hospital. So if the whole community started wearing masks, the hospital wouldn't be able to get the supply that we needed for frontline healthcare workers to do the job that they need to in a safe environment. So from that point of view, I had concerns about it. If you want to make your own mask, sure, that's fine. The second issue I had with masks is it might give people a false reassurance that the symptoms that they're experiencing are fine. I've got a bit of a runny nose, but I'll wear a mask so that I don't infect other people, and because I need to do my shopping. So the problem with that is that you exude virus a lot from your nose and your mouth, but also your hands, so you're still touching things. So I've concerns that would give false reassurance to people who might have mild symptoms, when in truth, when they've got mild symptoms, they need to be staying at home. The third thing is, for people who don't have any symptoms, is it gives them a false reassurance that going out is okay. One of the things which people tend to do unconsciously when they're wearing a mask is they touch their face a whole lot more. I was wearing a mask this morning. It wasn't one that I was particularly used to. It was a new style of mask that we had on the ward, and it was a little bit ill-fitting. I was seeing a patient who's been tested for coronavirus but hasn't come back negative yet. And I was constantly moving the mask. Even though I'm a healthcare worker, I know that I shouldn't be doing, but because it was falling off my mask, it didn't fit my face properly, a whole bunch of things. So every time you touch the mask, you're moving things from the mask to your hands and back. And really, that is not the way to wear a mask. If you're going to put a mask on, you've got to leave it on and don't touch it. But people will be touching it unconsciously more than they would if they didn't have a mask at all. So I think what's more important is hand washing. So I've got a little sanitizer bottle that I carry with me everywhere. So when I go to the shops, I just take this with me. I got this from Poor Tom's Gin Distillery that are now making hand sanitizer. But any sort of hand sanitizer would work. And I think essentially the way I view my hands and everything around me is, imagine everything is coated in honey. And so if you touch something, you've got sticky fingers from the honey, you have to clean it off with some hand sanitizer after every touch. So when I go to I do my shopping in in the junction. I see people going up the escalator and they're holding on to the side of the escalator things. If you need to hold on, that's great. But at the end of holding on, sanitize your hands, okay? After everything you touch out in the community, presume that everything is covered with coronavirus, and sanitize your hands appropriately. And that will significantly reduce your risk of getting coronavirus far more than a mask will.
You know, I can't believe it. I just looked up and I can see that it's already 12, and I don't know how that happened.
That went very quickly.
Yeah, Paul, I mean, thank you for your excellent discursus at the beginning, talking about, first of all, life inside the hospital. And even though you guys haven't, come across the heavy cases yet, we will do our best as a community out there to maintain the policies that are being put forward through the government, because I think they really are being very well guided, as you say, by the scientific and medical community. So I encourage all the participants and listeners today to take heed to that. I know I could see by some of the questions we didn't have a chance to get to that there's some chomping on the bit to get back out there on the streets, to the restaurants, to the beaches, to these kinds of things. I think Dr. Hamor's advice was sit tight that little bit longer. The curve is flattened, but we're not out of the woods yet. And so let's just keep on with this. And I also, as someone from the spiritual tradition where Judaism always says, your health and the advice of the doctors is so much, central to who we are as human beings. Let's listen very carefully to the government's putting forward this app for making sure that we have contact tracing much more adequate and easier to monitor. Let's not, look at, I will look at it as well, but I really think the notion of that is as the beginning of the surveillance nanny state, it may be a bit overblown, especially because you can always delete the app, and there's going to be, I think, strong indication they're not going to be storing that information beyond its purposes. So that's what I would like to share with you in response to what Paul shared with you, and to just thank everyone for being here. Paul, I want to thank you, the doctors, the nurses that are there ready for the events that could unfold, for all that loving care, and just wish everyone out there every blessing. Stay tuned for the future activities from Emanuel Synagogue. There'll be daily notifications. And again, on behalf of everyone, to a long-standing, from the moment of his birth to this very moment, member of Congregation Emanuel Synagogue, I want to thank Dr. Paul Hamor. Thank you very much.
Thanks for having me. Thanks for having me. And thanks everyone for your questions. Sorry we didn't get around to everyone.
More soon. Take care.
Okay, bye.
Bye.